Every few minutes, another family sits in a doctor's office and hears the word dementia. And in a number of those rooms, the real story never gets told because nobody ever looked at the pill bottle on the nightstand. I'm Dr. Sarah Bennett, and after years of practicing internal medicine with older adults, I have seen this pattern more times than I care to count. A person who is mentally sharp their entire life begins missing appointments, repeating questions, losing their way on a drive they've made for decades. Their family calls it aging. Often, it isn't. It's a medication. One that was prescribed by a trusted doctor, filled without a second thought at the pharmacy, and never once flagged as something that could touch the brain at all. Here's what a growing body of research out of institutions like the University of Washington and published in journals such as JAMA Internal Medicine has been showing for close to a decade now. A specific class of everyday medications, the kind sitting in millions of medicine cabinets right now, can measurably raise the risk of cognitive decline over time, and most people taking them have never been told. Today, I'm walking you through 8 of the medications most closely linked to memory loss in seniors, counting down from the ones that quietly slip under the radar to the one I believe deserves the most attention of all. Stay with me for number 3, because it's one of the most commonly used drugs in the country, and very few people realize what it may be doing over time. Before we get into it, I'd love to know in the comments, how many prescriptions are you currently taking? It helps me understand who's watching and what to cover in the next video. Let's begin at number 8, and don't underestimate this one just because it's sold without a prescription. Number 8 is diphenhydramine, better known by its brand name Benadryl. It's the go-to pill for a scratchy allergy, a restless night, or the first sniffle of a cold. Because you can grab it off an open shelf without ever speaking to a doctor, most people assume it must be mild. Inside an aging brain, the picture looks different. Diphenhydramine belongs to a family of drugs called anticholinergics, medications that block a chemical messenger called acetylcholine. Acetylcholine is central to how your brain forms new memories and stays alert. As we get older, the brain naturally produces less of it, which means it has less room to absorb a drug that blocks it further. The structure that feels this most is the hippocampus, the part of the brain responsible for turning short-term experience into lasting memory. The clearest evidence here comes from a landmark study led by Dr. Shelley Gray at the University of Washington, published in JAMA Internal Medicine in 2015. Researchers followed thousands of older adults for years and found that those with the highest cumulative use of strong anticholinergic drugs, including diphenhydramine, had roughly a 50% higher risk of developing dementia compared with those who rarely used them. A separate large study out of the United Kingdom, published in 2019 in the same journal, echoed the finding using health records from tens of thousands of patients. This isn't a fringe theory. It's one of the more consistently replicated findings in geriatric medicine. So what do you actually do with this? If you reach for a nighttime allergy pill, a PM sleep aid, or anything labeled nighttime relief, check the active ingredient, because it is very often diphenhydramine in a different package. Newer antihistamines like loratadine don't cross into the brain the same way and are considered a gentler option for long-term allergy control. And I want to be clear about something I'll repeat throughout this video. Never stop a medication on your own. Bring this list to your doctor or pharmacist and have an honest conversation. The goal isn't fear, it's awareness, because awareness is the one thing that lets you actually do something about it. Number 7 is a medication many people take every single day without ever questioning it, because the moment they stop, the discomfort comes right back. Number 7 is the proton pump inhibitors. Medications like omeprazole and esomeprazole, prescribed for heartburn and acid reflux. They work by shutting down acid production in the stomach, and for many people, they bring real relief. The trouble is what long-term acid suppression can do beyond the stomach. Your body needs stomach acid to properly absorb certain nutrients, and one of the most important is vitamin B12, which plays a direct role in protecting nerve function and brain health. reduce acid production for years at a stretch, and B12 levels, along with magnesium, can quietly decline without an obvious warning sign, sometimes producing confusion and memory trouble that can be mistaken for early dementia when the actual cause is a nutrient deficiency. Several observational studies, including a widely discussed 2016 analysis published in JAMA Neurology involving tens of thousands of older German adults, found an association between regular proton pump inhibitor use and a higher likelihood of a dementia diagnosis. It's worth being honest here. Later reviews and follow-up studies have produced mixed results, and most researchers now describe the link as an association worth monitoring rather than settled proof of cause and effect. Still, the nutrient concern alone is well established and reason enough to pay attention. If you've been on one of these medications for years out of habit, that's worth raising with your doctor. Many people can step down to a gentler class called H2 blockers or manage symptoms through diet and timing of meals under medical guidance rather than on their own. Number 6 is prescribed for a problem most people would rather not bring up out loud. Number 6 is the anticholinergic bladder medications, and the name to know is oxybutynin. It's given to older adults dealing with an overactive bladder, that sudden, urgent need that can reshape an entire day around knowing where the nearest restroom is. The relief it offers is real, but oxybutynin works through the same mechanism as diphenhydramine, blocking acetylcholine, and it crosses into the brain quite readily. That's exactly why it appeared prominently in the same University of Washington research I mentioned earlier, and why it's flagged specifically in the American Geriatric Society's BEERS criteria, a widely used guideline that identifies medications considered higher risk for older adults. Taken month after month, year after year, this is one of the more concerning entries on this list. The pattern I see in practice is familiar. Memory slips get written off as ordinary aging, forgotten appointments, misplaced keys, a foggy afternoon, and it's rarely connected back to the small pill taken for bladder control. If this describes you or someone you love, know that newer medications like mirabegron work through an entirely different pathway that doesn't block acetylcholine and may offer similar relief with meaningfully less cognitive risk. That's a real option to bring up at your next appointment. Number 5 is one of the most widely prescribed groups of medicines in the country for anxiety and sleep, and it deserves a careful, honest look. Number 5 is the benzodiazepines, medications like lorazepam, diazepam, and alprazolam. They work by boosting a calming brain chemical called GABA, and at first they can feel like genuine relief, easing panic, quieting racing thoughts, finally allowing sleep. Research, including large cohort studies published in journals such as the BMJ, has found associations between longer-term benzodiazepine use and increased dementia risk in older adults, with longer-acting versions like diazepam showing stronger associations, likely because they linger longer in the body's fatty tissue, including the brain. Here is the one rule I want you to hold on to if this applies to you. Never stop a benzodiazepine abruptly on your own, because withdrawal can be genuinely dangerous, including seizure risk in some cases. If you've been on one for more than a few weeks, any change needs to happen gradually and under a doctor's supervision. Safer long-term alternatives exist, including certain non-sedating anxiety medications and structured therapy approaches specifically designed for insomnia, and they can bring real relief without the same long-term costs to memory. Number 4 is a single pill quietly prescribed for 3 or 4 different problems at once, which is exactly why so few people question it. Number 4 is amitriptyline, an older generation antidepressant still commonly used today for nerve pain, migraine prevention, and sleep. Its versatility is part of the problem because it looks like a harmless, do-everything medication. Underneath that reputation, amitriptyline is one of the most strongly anticholinergic drugs still in wide use, meaning it blocks acetylcholine, the same brain chemical every medication on this list has been chipping away at. In the same landmark University of Washington research published in JAMA Internal Medicine, tricyclic antidepressants like amitriptyline were among the medication classes most strongly associated with cumulative dementia risk when used at higher doses over extended periods. What makes this one particularly worth flagging is how ordinary the dose often is. Many people aren't taking amitriptyline for depression at all. They're taking a small nightly dose for sleep or chronic pain. And because the dose feels modest, nobody connects it to anything serious. Over years, that steady, low-level exposure can add up. If you or someone you love takes amitriptyline, this is worth a real conversation with your doctor. For nerve pain, alternatives like duloxetine or gabapentin can offer relief without the same anticholinergic burden. For sleep, options like a very low dose of doxepin or non-drug approaches such as cognitive behavioral therapy for insomnia are generally considered gentler on the brain over the long run. Number 3 is the one I asked you to watch for at the start of this video, because it's prescribed to millions of people for something that sounds completely modern and safe. Number 3 is paroxetine, an antidepressant that belongs to a family called SSRIs, generally considered one of the safer classes of psychiatric medication available today. Here's the detail that gets left out. Paroxetine is the one widely used SSRI with meaningfully stronger anticholinergic activity than its siblings, like sertraline or escitalopram. That single distinction is why the American Geriatric Society specifically includes paroxetine on its Beers criteria list, the same guideline I mentioned earlier, as a medication to generally avoid in older adults when reasonable alternatives exist. The irony is hard to ignore. This is a medication meant to steady the mind, and in some older adults, sustained use has been associated with measurable declines in short-term memory and processing speed. If you're taking paroxetine, that doesn't mean panic. It means it's worth asking your doctor whether a different SSRI might serve you just as well with less cognitive weight attached. This is never a decision to make alone, since stopping an antidepressant abruptly can cause its own difficult withdrawal symptoms. It's a conversation, not a unilateral choice. Number 2 disturbs me more than almost anything else on this list, because so many people taking it never agreed to take it in the first place, at least not knowingly. Number 2 is the antipsychotic medications, drugs like quetiapine and risperidone. They were developed and approved for serious conditions like schizophrenia and bipolar disorder. In practice today, they're frequently prescribed off-label to older adults for sleep difficulties, restlessness, or the agitation that can accompany dementia itself, often in nursing facilities managing many patients with limited staff time. The FDA has issued a boxed warning, its strongest safety warning, regarding increased risk of death when these medications are used in older adults with dementia-related psychosis. And research has also linked their use to accelerated cognitive decline, increased fall risk, and stroke. If you or a loved one has been placed on one of these medications, the first question worth asking the prescribing doctor is simple. Why was this started, and is it still necessary? Often, agitation and restlessness in older adults can be eased through non-drug approaches first: consistent routines, treating underlying pain, improving sleep, and light exposure. When medication truly is needed, the guiding principle should always be the lowest effective dose for the shortest necessary time. Number 1 is not a single drug at all, and in many ways, it may be the most important idea in this entire video. Number 1 is anticholinergic burden, the cumulative, stacking effect of taking several of these medications at the same time, even when each one on its own looks perfectly reasonable. This is the piece almost nobody explains at the pharmacy counter. Picture a common, entirely realistic scenario. An older adult takes an antihistamine at night for allergies. oxybutynin during the day for bladder control, and a low dose of amitriptyline for nerve pain. Individually, a doctor might look at each prescription and see nothing alarming. Added together, the combined weight on the brain's acetylcholine system climbs considerably, and that total burden is what the research increasingly points to as the real driver of risk. This idea, often called anticholinergic burden, is well established in geriatric pharmacology, and it's exactly what the University of Washington researchers were measuring when they tracked cumulative anticholinergic exposure rather than any single drug in isolation. It's also the foundation behind tools like anticholinergic burden scales, which pharmacists and geriatricians use to add up the combined cognitive load of a person's entire medication list, not just one prescription at a time. And here's the part that genuinely gives me hope. And honestly, it's the reason I wanted to make this video in the first place. In many documented cases, drug-related cognitive decline is at least partially reversible when it's caught early enough. Reduce the burden, and people often regain real clarity, sometimes within weeks, sometimes over a few months, once the medications weighing on the brain are addressed. This doesn't require a dramatic intervention. It requires one careful, unhurried medication review. Sit down with your doctor or, even better, a pharmacist trained in geriatric medication management and go through every single thing you take, prescription drugs, over-the-counter pills, and supplements included. Ask directly whether any of them carry anticholinergic activity and whether safer alternatives exist for the ones that do. This single conversation is, in my opinion, one of the most underused tools in preventing unnecessary cognitive decline in older adults, and it costs nothing but time. I want to be honest with you about the limits of what we know. Most of the research connecting these medications to dementia risk comes from large observational studies, the kind that can show a strong and consistent association but can't fully prove that a drug is the direct cause in every single case. Aging is complicated, and memory changes have many contributing factors. What the evidence does show clearly across multiple independent research groups and consistently over nearly a decade is that this is a real signal worth paying attention to, not something to dismiss and not something to panic over either. It is, above all, something worth discussing with the people managing your care. So here's what I want you to take from today. If any of these 8 medications are sitting in your cabinet right now, that isn't a reason for alarm. It's a reason for a conversation. Write down what you're taking, bring it to your next appointment, and ask the question directly. Could any of this be affecting my memory, and is there a safer option? Drug-related memory changes are among the few causes of cognitive decline that can genuinely be addressed once they're identified. And that makes this one of the most hopeful conversations you can have with your doctor this year. I'd like to hear from you. Which of these medications are you currently taking, and have you noticed any changes in memory or focus since starting one of them? Tell me in the comments, and if this helped you understand something you'd never been told before, consider sharing it with someone who takes one of these medications daily. It might be the conversation that changes their next 10 years. And before you go, there's another part of the body that quietly reveals health problems long before a diagnosis ever does. I'll be covering that next, so I'll see you in the next video.